Oxygenation. Clients frequently are unable to meet their oxygenation needs, often as a result of an ineffective pump or an ineffective gas exchange. Neural and chemical regulators control the rate and depth of respiration. They work in response to changing tissue oxygen demands. Students have to be familiar with the structure and the function of the cardiopulmonary system. Cardiopulmonary physiology involves the delivery of deoxygenated blood to the right side of the heart and the pulmonary circulation, and of oxygenated blood from the lungs to the left side of the heart and the tissues. The right ventricle will pump blood through the pulmonary circulation. The left ventricle pumps blood through the systemic circulation. It is really important to be familiar with the cardiac system as we're discussing the respiratory system because they are so closely interrelated. Myocardial contractility will affect the stroke volume and cardiac output. Heart rate will affect blood flow because of its relationship between rate and diastolic filling time. With an increased heart rate, there's less time for the heart to refill with blood, so the stroke volume and cardiac output are decreased. Normal sinus rhythm originates at the SA node and follows the normal sequence through the conduction system. The P wave represents the electrical conduction through both atria. Atrial contraction will follow the P wave. The PR interval represents the impulse travel time through the AV node, bundle of His, and Purkinje fibers. The length of the PR interval is 0.12 to 0.20 seconds. Greater than 0.20 seconds is equivalent to a first-degree AV block. The QRS complex will indicate the duration electrical impulses as they travel through the ventricles. The normal QRS duration is 0.06 to 0.10 seconds. Anything greater than 0.10 seconds is equivalent to a bundle branch block. And the QT interval represents the time needed for the ventricular depolarization and repolarization. The exchange of gases occurs between the environment and the blood. Spirometry measures the volume of air that enters or leaves the lungs. Perfusion is the ability of the cardiovascular system to pump oxygenated blood to tissues and return deoxygenated blood to the lungs. Atelectasis is defined as the collapse of alveoli preventing the normal exchange of oxygen and carbon dioxide. And tidal volume is the amount of air that is exhaled in a normal breath. Physiological factors that affect oxygenation include respiratory disorders. There's 4 basic factors that influence circulation, perfusion, and transport of respiratory gases to the tissues. They're physiological, developmental, lifestyle, and environmental. And with cardiac disorders, any condition that affects cardiopulmonary functioning directly affects the body's ability to meet oxygen demands. We also have CNS alterations such as phrenic nerve paralysis or injury, and with chronic diseases, cystic fibrosis, polymyositis, and Guillain-Barré syndromes. Illnesses and conditions that affect cardiac rate, rhythm, strength of contraction, and blood flow through the chamber and peripheral circulation causes altered cardiac functioning. An altered cardiac output will cause left-sided or right-sided heart failure. Valvular dysfunction will cause a backflow of blood that results in a murmur or a whooshing sound as you're listening. Myocardial ischemia are the sudden decreases in coronary blood flow or an increase in myocardial oxygen demand without adequate coronary perfusion. Common results are angina, an MI or myocardial ischemia, or acute coronary syndrome, ACS. ACS is different than angina. It includes unstable angina, non-ST segment elevation MI, and ST segment elevation MI. An MI occurs because ischemia is not reversed. Cell death will occur after 20 minutes. And congestive heart failure is common following an MI due to the heart's ineffective pumping ability. Hyperventilation is caused by anxiety, infections, drugs, acid-base imbalance, fever, aspirin poisoning, amphetamine use, to name a few. Causes of hypoventilation would be atelectasis, collapsed alveoli, opioid, and CNS depressants. Signs and symptoms of hypoventilation include dizziness, headaches when you wake up, lethargy, dysrhythmias, electrolyte imbalances, convulsions, coma, and cardiac death. Causes of hypoxia include anemia, cyanide and CO2 poisoning, septic shock, pneumonia, atelectasis, cardiomyopathy, spinal cord injury, and head trauma. Changes can occur in the respiratory and cardiopulmonary system over the lifespan. Developmental stage and age can affect tissue oxygenation. In infants and toddlers, we are looking at upper respiratory infections and airway congestion, immature immune systems, and exposure to secondhand smoke. With school-age children and adolescents, we are looking at exposure to respiratory infections and secondhand smoke, and some of these kids may begin smoking themselves, or inhalation of aerosols, etc. The young and middle-aged adults are exposed to cardiopulmonary factors, unhealthy diets, lack of exercise, stress, cigarette smoking, over-the-counter drugs, illegal substances, and pregnancy. And older adults begin to have calcification of valves, conduction problems, atherosclerosis, left ventricular dysfunction, and myocardial muscle thickening. Deviations from normal can create problems in cardiac and respiratory systems that will affect oxygenation. So when you begin your assessment, there's several things listed here for you to look for, including with dyspnea. This is the clinical sign of hypoxia. You will see exaggerated respiratory effort with the use of accessory muscles, such as the abdominal muscles, the neck muscles. You might see some nasal flaring and rate and depth changes. With the cough, you always want to look to see or ask if it's productive, and if it is productive and they cough something up, yes, you need to look at it so you know what color it is, consistency, etc. How frequent is the cough, and are there times when it's more or less frequent? Health risks are increased with lifestyle choices and genetics. And medications. What is the client using to help with cough or breathing difficulties, and is it working? With the physical examination, you always do your inspection. You look at the skin and mucous membranes for color, appearance, level of consciousness, circulation, breathing patterns, and chest wall movement. With palpation, you assess thoracic excursion, tenderness, identification of thrills, heaves, tactile fremitus, and the point of maximum impulse. Palpation of the feet and the extremities can identify edema and arterial blood flow also. Percussion will detect presence of abnormal fluid or air in the lungs, and auscultation identifies normal and abnormal heart and lung sounds. With the excursion, this is a deviation from normal. The thrills is a very fine vibration. Heaves are chronic pulmonary disease with wheezing, coughing, or dyspnea with exertion. And tactile fremitus is defined as palpable vibrations on the chest when the client's talking. These can be absent or decreased if the client suffers from COPD. These are some of the diagnostic tests that you may see with the respiratory and cardiopulmonary systems. And as usual with your nursing diagnosis and planning, make sure that you use the NANDA approved list and make sure that you individualize your planning for the client. Implementation. We need to look at health promotion. When we help promote health, then we decrease the incidence of illness and decrease healthcare costs, improve patient outcomes, etc. We look at the vaccinations, such as the flu vaccine. It is recommended for children between 6 months and older, adults over 50, those clients that have chronic illnesses, and those clients that are in high-risk groups, such as healthcare providers, the immunosuppressed, and those who are HIV positive. The pneumococcal vaccine is recommended for those clients over 65 years of age, those who are at risk for pneumonia, or those with chronic illnesses or immunosuppression, such as AIDS or HIV. And then we look at environmental. People who work as farmers, painters, or carpenters, for example, might benefit from the use of a particulate filter mask to reduce the inhalation of certain particles. When we're managing dyspnea, we need to realize that oxygen flows might need to be increased. Treatments are going to be individualized, and more than oxygen therapy can be implemented. We can teach proper coughing techniques to help keep the airway patent and free from obstruction. Coughing helps mobilize secretions. Deep breathing exercises, usually mixed with coughing exercises, can also help keep the airway open and help keep the alveoli open. Humidification is necessary for clients that are receiving more than 4 liters of oxygen per minute, and it is required for pediatric clients. Nebulization adds moisture or medications to inspired air by mixing particles of moisture with varying sizes with the air. And chest physiotherapy can also mobilize secretion. This includes postural drainage, chest percussion, and vibration. A lot of times with dyspnea management, we work collaboratively with respiratory therapy. If you suction the client too much, they can be at risk for hypoxemia, hypotension, dysrhythmias, and trauma to the mucosa of the lungs. Make sure that you're monitoring vital signs and you stop immediately if complications occur. And remember, suction for no longer than 10 to 15 seconds at a time. Artificial airways are used for clients that have airway obstructions, decreased levels of consciousness, and ineffective breathing patterns. We maintain and promote lung expansion by positioning. The most effective position for promotion of lung expansion is the 45-degree semi-Fowlers. It helps use gravity to assist in lung expansion and reduces pressure from the abdomen on the diaphragm. Incentive spirometry. This encourages voluntary deep breathing and prevents and treats atelectasis. This is where they blow on the machine or they suck on the machine to raise a little level to see how much air they can take into their lungs or how much air they can blow out of their lungs. And then we have chest tubes. Chest tubes are placed for a pneumothorax or a hemothorax. A pneumothorax is a collection of air in the pleural spaces. A hemothorax is an accumulation of blood and fluid in the pleural cavity between the parietal and the visceral pleura. It's usually due to a trauma. There's different types of chest drainage systems. We have the closed drainage system with a single chamber. We have a second type that has two chambers. And a newer type is the dry chest tube system. It doesn't use water in the suction chamber. And all of these can be hooked up to a very, very low continuous wall suction. With maintenance and promotion of oxygenation, you need to work collaboratively with respiratory therapists when delivering oxygen to your clients. To restore cardiopulmonary functioning, or CPR, you have to understand that cardiac arrest is the sudden cessation of cardiac output and circulation. It can cause permanent heart, brain, and tissue damage within 4 to 6 minutes of no circulation. The purpose of CPR is to circulate oxygenated blood to the brain and to prevent tissue damage. The American Heart Association strongly suggests that defibrillation is administered as soon as possible to improve survival chances. And if you have it available, always use 100% oxygen during CPR. Cardiopulmonary rehabilitation will help the client achieve and maintain an optimal level of health through controlled physical exercise, nutrition counseling, relaxation and stress management techniques, medications, oxygen, and compliance. Hydration will help keep mucus clear, thin, and watered down. So we need to make sure that our clients are drinking sufficient amounts of fluid. We can teach different coughing techniques, such as the cascade cough, where the client takes a slow, deep breath and holds it for a couple of seconds while contracting the expiratory muscles. Then they open their mouth and perform a series of coughs throughout their exhalation with progressively lowered lung volumes. The huff cough simulates a natural cough reflex, and it's effective for clearing the airway. The quad cough is performed by clients that don't have the abdominal muscle control while breathing out with a maximal effort. We can teach pursed lip breathing, which is a deep inspiration and then a prolonged expiration through pursed lips to prevent alveolar collapse, and it does this by decreasing intrathoracic pressure. Diaphragmatic breathing requires the client to relax intercostal and accessory muscles while taking deep inspirations. And always remember that elevation of the head of the bed can improve respiratory function, and it should be one of the first interventions performed if a client experiences dyspnea. Diseases or conditions that require oxygen therapy include pneumonia, COPD or the chronic obstructive pulmonary diseases, other respiratory illnesses, cardiovascular diseases, and always with chest pain. Oxygen administration. You have to remember that oxygen is a medication, so we require the 6 rights of medication administration. You need to monitor the dosage or the concentration of the oxygen. It can become toxic, or carbon dioxide retention can occur. Do not use petroleum-based products with oxygen, because petroleum-based products are flammable, and oxygen supports combustion. Miscellaneous things with oxygen administration: make sure you monitor the skin for irritation or breakdown with cannulas over the ears, in the nose, with masks around the bridge of the nose, the chin, the cheeks, again over the ears. Realize that the nasal cannula is the best tolerated delivery system. Portable oxygen should be used with ambulation and/or transfers if the client does not tolerate room air. And again, oxygen supports combustion. These are signs and symptoms of hypoxia. I realize I have that spelled wrong, and I apologize. And you need to be familiar with how much oxygen, or FiO2, is going to be delivered with the different delivery systems. With the nasal cannula, you can administer 1 to 6 liters of oxygen. You cannot deliver higher than that unless you have a high flow nasal cannula. But typically 1 to 6 is standard, and it will deliver 24 to 44% FiO2. Their breathing pattern can affect the FiO2. A simple mask, oxygen should be set at 5 to 8 liters per minute, and it will deliver 40 to 60% FiO2. Your non-rebreather mask can deliver oxygen from 6 to 15 liters, and it will deliver 60 to 100% FiO2. It will provide the highest possible oxygen level without intubation.